this is no longer a choice. 70% of NHS expenditure and 70% of secondary and tertiary beds in this country are clogged up with patients suffering from chronic diseases, often comorbid, that should be preventable and should be dealt with in the community. And so I think if we don't deal with that now, imagine the pressure on the healthcare service in 20 years' time. It's unimaginable.
So, good evening. Thank you all for coming and welcome to Question Time. Levelling up the conversation, making the UK a life sciences superpower. This is the first of a series of local events that we're doing. And the whole objective is very much to get life sciences policy out of the Westminster bubble and into the localities where actually it's going to be implemented, we would hope. My name's Angela McFarlane. I'm Vice President for Strategic Planning Northern Europe at IQVIA, and I'm clearly going to be chairing tonight's proceedings. We've got a really interesting and important topic ahead of us tonight. But as we look out to the rest of the world with that global life sciences superpower vision, and the future, of course, we've got to remain acutely aware of the urgent crisis that our partners in the NHS are dealing with. So not only COVID itself and the backlogs, urgent emergency care, the unintended consequences of the COVID lockdown. We're looking at the moment with 7 million people on waiting lists, plus 2 million emergency operations a year. We've got 8 million elective operations in a normal year. And of course, those unintended consequences of COVID, so people not presenting early enough for cancer and many other conditions, which leads to potentially another 2 million people who are yet to turn up and present, and with whatever is going on in mental health. So thank you all for following COVID rules, doing your tests today, having your vaccines, and thank you to our NHS. And we have many NHS clinical leaders in the room here tonight, as well as joining us on the webinar. So thank you so much. On your seats, you'll see some case studies from IQVIA briefing the programmes that we're doing, that we've got live at the moment to support NHS recovery. So take time to have a look. We've got everything from stratifying patients on waiting lists to apps to support the mental health of patients on those waiting lists, and bringing capacity through clinical pharmacists to support primary care, avoid unplanned emergency admissions. So do follow up with us on any of those, should you so wish. So now to the matter in hand and the format for this evening. We've got a real mixture of questions, and thank you all, those of you that sent them in advance. It's been quite a job, quite a task for Ben and myself and Miles to go through those and sift them in, but we have done so. And what we've tried to do is put them into buckets, as you'd probably expect, around things like access, around Cambridge itself, around health inequalities. So if you're with us in Cambridge tonight and I call your question, we'll get a mic to you. Don't worry if it's like a choice from a menu and you can't remember the question that you asked. I've got it here. We've also asked some of our webinar guests to record their question for this evening, but some I'm going to personally read out. So to our guests and panelists, I'm just going to ask that you keep your questions and answers concise. We received a lot of great questions, and I'd like to get through as many of those as possible. And I really don't want to have to pull the lever, my fellow panelists, on the chair like Graham Norton on a Friday night, especially not these chairs. It wouldn't be a very relaxing tip back. So keep your answers concise. We're also going to be asking poll questions to make sure that we get as many of you involved real time as possible. And that really, I always think, puts colour and light on any event like this, whether it's hybrid, virtual or in person. So may I, first of all, welcome our panellists. We have Minister George Freeman, who is Minister for Science, Research and Innovation. It's George's second time around as a minister with a science brief. He was formerly Minister for Life Sciences, And those of you who had the privilege of working with him last time will know that he is a minister that makes a difference. We've got Dr. Nick Johnson, who is the Mayor of Cambridge and Peterborough. So welcome, Nick. Delighted to have you here tonight. We have Michelle Mitchell, who is the CEO of Cancer Research UK. And may I thank Cancer Research UK for giving us this beautiful home tonight. We have Dr. Julia Wilson, who is Associate Director at the Sanger Institute. Welcome, Julia. And last but by no means least, we have Tom Keith Roach, who is the UK President of AstraZeneca, who of course have a very strong footprint here in Cambridge. So welcome to everybody. I'm also delighted to welcome a member of the Shadow Cabinet in the audience tonight, Daniel Zeitner, MP for Cambridge and Shadow Secretary for Environment, Food and Rural Affairs. Daniel, I believe, does have a question. I don't know if Daniel's actually got here yet. Daniel, can I see you? Because I can't see any of you behind the mouse. I know he's on his way.
Stuck in the traffic.
Yeah, that is also a topic for tonight. You won't be surprised to hear. So without further ado, let's now move to our first poll question. We're not going to be technology oriented tonight. You haven't all got buttons you can push, but you do have a good old fashioned hand. So what I'd like you to do when I ask the question is raise your hand to whichever particular piece you most agree with. And I'll do my absolute best to make sure that I'm reflecting back to the webinar audience what it is you're saying. So first of all, and I'm going to repeat this question at the end, so no pressure, panelists. On a scale of 0 to 10, with 0 being not confident at all and 10 very confident, how confident are you about the future of the UK life sciences sector? So if you are not at all confident or not very confident, can you hold up your hand now? Okay, thank you very much. Which leaves the majority. Raise your hand, just get into practice. Somewhat confident or very confident. So thank you for that. We're going to revisit that and see if you're not isolated.
It's like Strictly Come Dancing, they need number paddles.
Yeah, we could very much do
10 from men.
Okay, so I'd like now to go first to the first question. This has come in from Uday Bose, who's Managing Director of the pharmaceutical company Boehringer Ingelheim. Somebody should be getting a mic to you, Uday. So if you raise your hand so they can see where you are, kick off with your question.
Thank you, Angela. So, so the first is a comment actually, which is the quality of the life sciences vision. I think globally, it's wonderful. It's the few governments globally who have set such a clear long-term strategy for a sector which is so important. The question I have for the panel is, how do you feel global boardrooms from the life sciences sectors see the UK? Because it feels like it's a tale of two sides. There's a fantastic innovation opportunity. But when you look at uptake of innovation, when you look at the commercial operating environment, when you look at the NHS's challenges, it feels like a paradox. So it's a question about the perspective that you feel global boardrooms have on the sector.
Uday, thank you. George, do you mind if I start with you?
No, because Uday's put his finger, it's the key question. And thank you for what you said about the clarity of the life science vision. It was born really of an answer to that question, that I think for years we've been recognised as a research superpower. You only have to see this campus as well as the rest of the UK campus, but not an innovation powerhouse. And at the heart of my mission as Minister for Science, Research and Innovation, I've made fundamental commitment, as well as being a science superpower, we're going to be an innovation nation. And that means a whole bunch of things to do with procurement, regulation, and driving clusters all around the country. But to your specific question, I suspect that the boardrooms around the world of global business, but some of them are here, would say, look, the UK has proven again that in terms of pure research and science, it's incomparable. I mean, it is the world leader. And, you know, you don't have to take my word for that. We've led the world in sequencing the COVID genome, developing the vaccine, and putting together the world's biggest clinical trial, bigger than the next 10 in the world, fast. And the NHS showed its potential. I mean, extraordinary moment. But I think they would say that in the last few decades, we've become less good at adopting innovation into the system. And that's why when we launched that original vision in 2010, and then in 2017, and then the update this year, fundamental to it is the NHS as a partner in our life science ecosystem. And I'm sure we'll talk about this tonight, but I think that's what global boardrooms would say is, great place to do research. We've got to make it a better place to get innovations adopted, tested. And our core strategy is the NHS is never going to pay top dollar, but we ought to be the research engine so that people around the world, whether with a device or a drug, would say, you've got to go to Britain, get it tested, find patients, get real world data, do your health economics, and then you can go and sell it around the world. And if we can make that engine, research engine work, I think we've got a really compelling proposition.
Thank you, George. Tom, can I bring you in that?
Of course, yeah. Thanks for the question, Uday, and for your comments, Minister. Look, I think we have an opportunity in the context of the life sciences vision, but also coming out of this pandemic. I think society now understands how important a thriving life science industry is to the UK. And I think we have two opportunities which are linked. One is to create a thriving life sciences environment, and the other is to make a step change in how we deliver societal good health through the NHS and address healthcare inequality. And actually, I do think these two things are linked together. I don't think in the long term you can be a leading scientific superpower if you're not also a leader in healthcare delivery. And I don't think you can be a leader in healthcare delivery unless you've got fantastic science. I think, as George says, we are unequivocally a global leader in terms of early research and science. That's why we built our global billion-dollar R&D headquarters just up the road, and we're surrounded by world-class institutions. But I think at the same time, we need to recognise that we've been slipping down the international rankings over the last 5 or 6 years, and I would just call out 4 areas. The first is our share of clinical trials internationally has dropped from 3rd to 7th over the past 6 years. The NHS doesn't have the capacity or the capability to keep up. So we now run less than 2% of global clinical trials in the UK. The second is data. I think we're at risk of talking about the NHS as if it's one organisation with integrated data sets, and actually it's not. It's an archipelago of about 20,000 in the UK, separate organisations. And when you think about the healthcare system data you need to conduct research and deliver population-level health, Finland, Sweden, and the city of Boston have better data sets than we do. We've got to fix that. The third is manufacturing. We don't have an attractive tax environment for advanced manufacturing investment. And so I find it incredibly hard in my role within AZ to attract the sort of manufacturing investments that I want here versus places like Ireland and Singapore. And in terms of exports in the context of Brexit, which should be a massive opportunity, we've actually slipped down from 4th to 9th over the last 5 years in terms of the value of our exports from the UK. And finally, I think we've touched on this. The NHS has a patchy record of taking up the innovation that's developed here. And so global boardrooms, frankly, think about the UK as a profoundly unattractive market for commercializing innovation. And that's why, although we have great early science, a lot of our companies, when they get into clinical development and think about commercialization, get funded and move to the US. We have to create an environment here where we haven't just got great science. Companies want to stay, they want to develop medicines here, they want to commercialize them here. And working with the NHS, we can get them into clinical practice at scale and eliminate healthcare inequality. That to me is what's so powerful about this dual element of the life sciences vision. We've had 100 life sciences policy documents in this country over the course of the last 6 years. We've got to start turning some of this rhetoric into action now on that agenda. It requires all departments of government. And I think what we've learned through the pandemic is this triple helix of partnership between private business, academia, and government is the way we need to proceed if we really want to deliver on it.
George, can I just go back to you on 2 of the points that Tom made there? So one, the data, and I love the archipelago, of separate organisations on data. And I know you've got some very, far-sighted thinking on how things might improve and the opportunity within ICSs for that to improve. But could I also just ask you, with regard to the access, I know you were one of the visionaries behind the Accelerated Access Collaborative. For many now, we see it as the Decelerated Access Collaborative, I'm afraid. Thoughts on that and what might need to happen, and again, bringing it back to a local conversation, how we can get that uptake at local level and how we can get this greater integration of data to improve health outcomes.
Yeah, absolutely. Well, firstly, I agree with everything that we've just heard. And of the 4 points you made, the one I'm most optimistic about is manufacturing, actually. And I'm right now in the process of post-CSR. We've made the biggest increase in R&D spending for a generation. It's a 30% increase. It's a lot of money. We're allocating 30 billion across the UKRI and Innovate and across the system. We're making a big move on manufacturing, because if we want to stop being just a discovery economy and be an innovation nation, then you have to go upstream. And actually, medicines manufacturing is becoming incredibly sophisticated, very smart, and we're good at it. So we are. On that, I'm more optimistic. I think on the data and the access points, the thing that's been most disappointing to me coming back to government is looking at the accelerated access piece. The thing that's been most exciting is the genomics piece. If we go back 10 years ago, our vision was clear. We were honest about our weaknesses globally, and we said, look, we can't pretend. We have got to tackle this, and we've got to have a compelling proposition for people to come to the UK. And it won't be the NHS paying top dollar for drugs. So what will it be? And a few of us set out in that a very clear vision that the NHS would be a research engine. But to do that, you've got to basically do two things. You've got to give access to genomics, tissues, data, all of those clinical assets. Actually, I think the genomics program, and we launched it to be a groundbreaking initiative, I think that has worked in spades. You only have to look around here and see. The danger was that it would be purely academic, not a medicinal service, but it isn't. We have an NHS clinical genomics program taking shape off the back of the Illumina contract, shattering of the cost of genomics, this cluster. So I think that's worked. But the thing I'm most disappointed in is the accelerated access piece. And I think that and the data go together, and the post-pandemic piece. In the pandemic, we put on as a nation £1 trillion of debt and 35,000 tons of fat. And if we're really going to harness the incredible enthusiasm, I've never in my wildest dreams expected to see the Wimbledon rise to salute a life scientist. I think the country has got that this is a huge strength. But I just think the pressure on the NHS to deal with the backlog, it means it's a lot to expect the NHS institutionally from top down to become quickly that research partner. What I think we could do and should be doing is to recognise where we're already really good. This Cambridge cluster is really good. Oxfordshire is catching us up. They're pretty good. Manchester is pretty good. The West Midlands is pretty good. Some of the London bits. I think we could create 6 or 7 place-based, population-based, sort of fit city programs. Get on the Fit City Birmingham, Fit Manchester, Fit Cambridge. Fitbits and other products are available. Use people's commitment to healthy living post-pandemic as the front end to a national data spine and clinical trials recruitment. And I think that way, if we had some disease portals, rare cancers, some diabetes respiratory run by the charities. Mr. Freeman, I'm sorry to tell you you've got a diabetes diagnosis. Good news is you've now got a unique password. You're into the app, join the community, find fellow patients, slide the consent bar to get into trials. I think if we created some place and disease front ends, we could really drive that opportunity. I just think asking NHS England and the Department of Health top down to command that it should happen isn't going to work. But if we let localities that are good at it free, by the way, you link those 6 places, that's 20 million patients. That makes us a global powerhouse in digital data sharing and trials. I think that's the key.
Are there any clinical leaders in the audience that want to comment? Ben's growling at me because I'm going skiing off piste here, but I do want to bring the audience in. So, gentlemen, do you want to say who you are, where you're from?
Yes, hi, I'm Miles Clarks. I'm a consultant gastroenterologist at the hospital here, and I'm the director of the Biomedical Research Centre here as well. I agree with your statement. I think just tipping 30 billion, 100 billion at the top end, it will make no difference down to the bottom end. What goes on at the grassroots level is, there are some pretty basic things: time, space, provision of facilities for processing DNA samples. We can't just click our fingers and make these things happen. They've actually got to be worked on and put in place. But I agree with you. I think the opportunity is there to make things happen in places which are halfway there already and where the populations are supportive of that. And for relatively modest amounts of infrastructure spend, you could actually get all the way there.
Thank you, Miles.
I would just say something to the point about pandemic, and since being Minister for Life Science, I've been Minister for Decarbonisation, Digitalisation of Transport. You would think I did as I walked across the DFT, it had nothing to do with health. Turns out, to deliver net zero and deliver an active, healthy economy are 80% the same thing. And one of the projects we're looking at is West Midlands, which is obesity capital of Europe. If we could start to create wouldn't it be amazing if we could create a framework where if a consortium came together and reduced the cost of obesity in the West Midlands, which is currently Treasury figures 4 billion a year, and could keep some of the saving and put it back into healthcare, we could really drive these collaborations of digital, therapeutic, early diagnostic, place-based. I think that's where the industry wants to go. And we need to move more quickly to help.
Okay. I'm going to move on to our next question now. So that comes in from Ben Osborne, who's Managing Director and President at Pfizer. And he's, sorry, forgive me, he's not President of Pfizer, he's Managing Director at Pfizer and President of the ABPI. Ben is on our webinar tonight, and his question to the panel is, what learnings can we take from the pandemic to bring a greater focus on prevention of disease rather than the heavy cost and time burden of controlling illness? Michelle, can I go to you first on that, please?
Yeah, absolutely. Well, we know, take cancer for an example, prevention is key. Governments have a big role to play in policy as well as research. So when we look at the modifiable risk factors with cancer, smoking, still a lot to be done there. When we look at obesity, lots, and alcohol. So looking to government to set a policy agenda as well as a partnership agenda with charities on life sciences, because we've heard a lot about industry, we've heard about government, but let's not forget charities have a huge role too. £1.9 billion a year is invested in research from bench to bedside from charities. So we want to see collaboration and partnership across prevention, early detection, and also treatment on cancer. And you were talking about levelling up inequalities agenda. It's absolutely huge. 30,000 avoidable cases of cancer are diagnosed each year as a result of deprivation. I mean, that is something that, deep in all of our hearts and needs action. So prevention, policy, prevention, investment in research, and right across, for us, early detection, diagnosis and treatment are key. And what we want to see in the life sciences strategy, which I agree with audience members earlier, that it's a great vision, good to see some money getting, backing it with this spending review, waiting to see those allocations, and really the plan and the implementation of those big ambitions is key. But don't forget the charities as well. And see us as key partners in improving health outcomes and survival in this country.
Thank you, Michelle. George?
Well, I echo that. And in a world where patient consent, patient genetics, patient data, patient tissues become more important, I think the charities become more important as portals. I think those disease portals would be run by charities, and then they can talk to industry about how to do research. But to answer that key question, I think there are three big learnings. One, carrying huge cohorts of chronic disease, obesity-related comorbidities costs you a fortune. And for the first time in my life, global business has realized how vulnerable it is to the cost of the, excuse the pun, the underbelly of neglected population health. I mean, the US and the UK were top of the global health security rankings. We were also hit hardest in terms of our avoidable COVID deaths because of obesity-related disease. So it's first learning. Second, I would say is that the data sets simply aren't there. And I say that as a constituency MP in Norfolk. We were waiting for national data to tell us when we could lock down. And it just wasn't there, and the integrated data wasn't there. And I think if you localize, you can make stuff happen much more quickly. And thirdly, I think part of the thing about the pandemic, I think in a genuine way, people got off the treadmill of daily commuting, and I'm conscious we've got a mayor with us. I think a lot of people got off the kind of, the slavery of the daily commute and the daily congestion, and heard the bird song and worked from home. And that's a really important point. I think there's a lifestyle change that can help ease congestion, ease pollution, maximize health. And if we get that, if we can seize that, I think we can make this country healthier, as well as the things we've been talking about in terms of policy and trials and data.
I'd like to come back to Nick on that with a question in a moment. Tom, did you want to come in there?
I mean, I just wanted to build on what my colleagues just said. This is no longer a choice. 70% of NHS expenditure and 70% of secondary and tertiary beds in this country are clogged up with patients suffering from chronic diseases, often comorbid, that should be preventable and should be dealt with in the community. And so I think if we don't deal with that now, imagine the pressure on the healthcare service in 20 years' time. It's unimaginable. And so I think within the new integrated care systems, there is a fundamental role for inspired commissioning to start to commission services upstream of wherever you are to prevent patients emerging in your institution 24 months from now. That means hospital commissioning needs to work differently. It needs primary care commissioning needs to work differently in the community. We need to start to invest in the social predeterminants of ill health and community. And as part of that, I think we really need to get behind this concept of community diagnostic hubs, but make sure we build the infrastructure in the places where they're disadvantaged.
But take the issue of cancer, where although we can all be delighted that we've seen a doubling of cancer survival in the last 40 years, we do lag behind right at the bottom of the comparable league tables. So in addition to research and innovation, bringing new ways to detect, diagnose and treat cancer, we have to look at how we adopt what's known, look at risk stratification screening, imaginative behaviour change campaigns, which brings people forward with signs and symptoms of cancer, faster diagnostics, proper workforce, speeding through the system at a much greater speed than we have today. And these are all ways in which charities, industry, the NHS can all work together on these big strategies and plans which have at the heart of them massive improvements for health outcomes for the British population.
Nick, can I just bring you in on that point about investing in the community? So forgive me, I'm putting a question there that Tom stimulated that isn't on the approved list of questions. But I know you're also a clinical leader.
Yeah.
So I think you'd have...
Yeah.
Anything?
Oh, sorry. Can you repeat the question again?
Yeah, well, no. Tom was talking about managing the upstream and ICS as being an inspired commissioning opportunity. But what they need to do is invest in the community upstream to prevent the clogging up that's going on downstream.
Well, for me, with the ICS, the first thing I've done this week is I've actually met the chair. And I think that's an important signature that with the combined authority lead coming in, and for those who know the circumstances, I've arrived on the scene, so plucked from the NHS. I'm very conscious if I give an answer, my answers may seem somewhat parochial because I'm here to represent Cambridgeshire and Peterborough.
And tonight's about Cambridge.
It is, but for me, as a combined authority lead, I have to talk about Cambridge and Peterborough. But what I want to say is that I've got the benefit of sitting here with a minister and a shadow minister at the thing, is that for me, talking as a leader for Cambridgeshire and Peterborough, I want to be here that message that public health, having come from the front line of dealing with COVID, and I continue to work there. On Tuesday I was there. These inequalities, and let's be clear, we must talk about inequalities. They made the biggest difference in terms of kind of lifetime survival. Now, I'm absolutely wedded, having given the opportunity to be a public voice in a political forum as a combined authority leader, to say we've got to do things differently. I don't think I'm like every other politician. Maybe all politicians say the same. But I've come into this with a view to saying you've got to look at this, kind of bring what I've learned over almost 30 years in the NHS. The NHS is a nationalised industry. It's been there and it's managed to survive upwards of 70 years. The reason is that people want to work within that environment and they want to give something. And despite the challenges about funding, which has always been there, doesn't matter which government you have, there's always a way to get things done, and you do it by collaboration. I talked about, and I'm going to use this opportunity to, I talked about 3 Cs. That's how I campaigned, and that's what I absolutely fundamentally believe in the strategic growth statement of our organisation. If you start with compassion, if you really look like you can, it doesn't matter if you're a big business, that's AstraZeneca, or if you're representing a kind of third sector, if you care in everything that you do in terms of the delivery of what you're trying to achieve, you will get the cooperation, the second C, and most importantly, you then start delivering for a community. So maybe I've gone a little bit off thing because you've given me the opportunity to speak.
I've been skiing off piste all night, so
that's kind of where...
No, that's great.
And I think there's a message that, I might be parochial, but I want to work on a national level. I might be the one of 10 metro mayors, but I want to be seen as a world-leading mayor, because I've got the benefit, a very lucky benefit, of being surrounded by this very place that drew me here when my wife first got a job at Addenbrooke's Hospital.
Thank you, Nick. Sorry to put you on the spot there. Justin Watling from Palantir. Can we get a mic up there? And then we're going to move in to our next poll.
Using the mask off. Thank you. It builds a bit on some of the earlier conversations, this sort of archipelago that we've been describing. I think the regional bit makes a lot of sense for driving research and things that are half done, completing them. But in the end, we need the innovation to work end to end. So we need to be able to get out of research, the regulator like MHRA make a decision, then get it into post-market surveillance where we can monitor those things across the market. The faster we introduce innovations, the faster we need to be digitally checking on safety and how those innovations play out. And then we need, of course, incentives for adoption and uptake, which gets into value-based models for commissioners to buy these things. And then we need to see how they're adopted. And at the same time, we're trying to move towards national deals for drugs and things like that as well. So I think in all of this, we do need to, are we going to create a national data architecture that solves that? And I don't mean it in a way like a care.data or a GPDPR where it's all just bucketed together, but where there's real control points in the market for data controllers and citizens to understand the purposes of how their data is being used. Perhaps, George, this is the sort of national spine idea that you're getting to.
So I'm going to put that question first to Julia, actually. So do you think the country is likely to invest, and should it, in a national data architecture? And then I'm going to pass that to George. Julia.
Well, you're right. It is a very complex landscape, and I don't think probably a single architecture isn't the answer. What we need, what has been discussed about data already this evening, is that federated approach where you can enter a data network through a single portal and access multiple different federated databases. Importantly, that process has to protect privacy, because we need to consider public trust in all the research and innovation that we're doing. We have made some great strides in the UK already with, for example, Health Data Research UK, that works to mobilise routinely collected health data for research. And there is a single portal you can enter to get access to data tools, data, publications, and research projects. We've also got trusted research environments. They may not be the answer to everybody's issue, but there has been investment in them, to provide approved researchers access to information, health information, and care data that they can use for research. Another novel idea that we're adopting in the UK is the idea of passports for researchers. So as a scientist or a researcher or a clinician in the system, you have a passport, you're authenticated, and you can access you're authenticated to access multiple databases to enable you to do your research as well. So there's a real opportunity for innovation in the data landscape as well. To come back to Justin's question, I think we need to bring together all the players in this ecosystem, as you say, from the basic researchers to the innovators through to healthcare, to shape what we all actually need to shape it as a community. So we move from this siloed data, these balkanized different data sets, where there's no connectivity and no interoperability between them. So that federated approach, interoperability is key.
Yeah, and don't forget what Tom was saying about all those separate, and Finland, Boston, and Sweden. Thank you. Yes. Having better data sets than us. George.
Yeah, 2 points. I know you asked us to be brief. The investment and then the market piece. So the answer is we are investing in that core data spine. But I would suggest that the history of health data in the last couple of decades in the UK is that actually governments poured billions into health IT, and it hasn't transformed frontline services or delivered an integrated research ecosystem. We've done bits and it's patchy, and so I don't think, often investment is the issue. I think this is about changing the way we incentivize investing and invest, tipping billions. When I was a Minister for Life Science, we got 4.2 billion from George Osborne. We promised paperless NHS by 2020. We just keep pouring money in, so I think we need to carry on investing. Second point, I do think, is what I was saying earlier, I think we have to take a different approach. It's urgent. In my 10 years I've been in Parliament, health has gone from 30% of national budget to about 42. It'll be 52 in the next 10 years. This is not sustainable. We can't keep filling up our hospitals with people with chronic diseases. So we've talked a bit about that digital aspect. I think we have to localize, integrate and incentivize. On the market piece, if Brexit hadn't interrupted my first mission as Life Science Minister, what I wanted to do was move into reforming the NICE NHS relationship. Remember, politicians set up NICE so that there'd be some health economic background behind the decision to say no. Well, the NHS is now independently run and perfectly capable of saying no on its own. And I worry that NICE is in danger of being drawn into being the sort of always saying no for the NHS. I'd like NICE to be more of an international, global health economics house, setting pathways. And it might be pathway into the NHS that'll save you money and lives, yes. This will save you lives, but not money. This will save you money, but not lives. This, you'll have to trial it for 2 years and check the data. I think clearer pathways and freeing up NICE to be more of a global health economics house, and then driving advice into the system that this innovation, you need to change the care pathway, and you should, to deliver benefits. I think unless we do that and the data localized, we're going to stay stuck in this pattern.
I think, George, some people might challenge you on the NICE piece there, because, NICE has actually done a pretty good job of saying yes more recently. Something like 95% of their appraisals are yes. The issue is implementation at local level and uptake at local level.
That's right.
And that brings us back to the local thing. Tom, do you want to come in on that?
Yeah, without opening the sort of access can of worms, and regardless of your politics, I think one of the opportunities to come out of Brexit is to think about the MHRA and NICE as globally leading organisations, fully empowered to innovate and to establish an access architecture for the 21st century. And we're starting to see that, to be fair. I think the work that NICE did around, the MHRA did as part of Project Orbis is the beginning, but it needs to be funded and resourced properly. Actually, as an industry, NICE probably has not been our best friend over the last 20 years, but it's objective. And we like the fact that we have an objective authority assessing the value of innovation within the UK, because actually the negotiation with NHS England is simply horse trading. It's about affordability, not about value. And so although there are things that NICE need to do, and we're going to come to some of that, I think, around more innovative types of therapy, NICE is very well respected. When I came to the UK, everybody told me, and George, you sort of used different words to describe this, that this was a slow and low access environment. I don't think anybody's saying that they expect the UK to pay sky-high prices for innovation. And actually, when you look at the data, what's interesting is we're not slow at adopting innovation everywhere. Actually, the most forward-thinking trusts and CCGs where they want to adopt innovation extremely fast. The problem isn't that we don't know how to do it fast. It's that there are some parts of the country that don't do it at all. And it's a massive driver of healthcare inequality. And so in a way, the default system and incentives within the NHS is resist innovation, apart from where you can break through with pockets of clinical and commercial leaders. I think that has to turn on its head. We have to say, once something has been proved to have value through NICE, albeit at a low price internationally, actually the burden of proof should then be on the local system as why they're not using it. And we need to give the CQC statutory powers to audit that and say, why is there unwarranted variation in care here? Why are you not adopting technology in front of patients that's been proven to improve outcomes and proven by NICE to be cost effective? So, it's a complex story.
Yep.
We do know how to do it. We just do it very, very inconsistently.
I'd add on some red, amber, green outcomes. When patients in Norfolk see that cancer outcomes are 4 times worse than in bits of London, people will start to say, why? Right. And it'll raise the political pressure, rightly. And so I totally agree with you. There's a democratic bit to this as well. And rather than pretend that everything is equal at the moment, people say postcode lottery. My answer is we already have one. At the moment, we need to be much more open about accountability.
Okay. And you talked about diabetes, right? In diabetes, just one example, the last NICE guidelines were written in 2015. Okay, so the laggards are not using any novel medicines that save lives and keep patients out of hospital. Whereas the more progressive trusts, 80% of their patients are on those classes of medicine. And so, it's not a mystery why we see such huge variations in care.
Okay. Right, I want to do the next poll question now, if I may, and then I'm going to move to questions around the Cambridge cluster. So, the next question, as you can see it up there, is how confident are you that the 7 life sciences missions, which were published just before Christmas from the Life Sciences Vision, will make a difference to the UK as a life sciences superpower? But before you answer that, I talked about getting policy out of the Westminster bubble and into the locality. Can I have a show of hands? Because we've had some quite interesting in language around the panel tonight. Can I have a show of hands for how many of you actually know or have heard of the government's life sciences mission? So if you've heard of it, put your hands up. Fantastic. You're qualified to answer the question then, don't you? And if I can just remind you, those 7 life sciences missions: accelerating the paces of studies into novel dementia treatment, enabling early diagnosis and treatments, including immune therapies such as cancer vaccines, sustaining the UK's position in vaccine discovery, development and manufacturing, treatment and prevention of cardiovascular disease and its major risk factors, including obesity, reducing mortality and morbidity from respiratory disease in the UK and globally, addressing the underlying biology of ageing, and increasing the understanding of mental health conditions, including working to refine diseases and develop tools to address them. So those are the 7 missions, and there's lots of granular detail behind them. So if you recall, 0 is you're not confident at all, and 10 is very confident. So can I have a show of hands that you are not very confident that those missions will make a difference to the UK as a life sciences superpower? Not very confident? Okay, 3 of you. Oh, sorry, a few more up there. And I'm going to do the opposite end of the spectrum, so moving to confident or very confident. Okay. So the confidence have it this time, but there were some people that abstained. So I'm not going to say the jury's out. The confident people had it. I'm now going to move, as I said, to the Cambridge cluster. Is Daniel Zeitner in the audience? Daniel, hello. You weren't in the audience last time, so welcome. We hoped you didn't get caught up in the traffic. So Daniel, would you like to put your question?
Well, I didn't actually have a question.
Oh, well, you did according to this, sir.
Oh, that's
How can we ensure?
Well, in which case, please read it to me, and I will relay it back to you.
Salmon or beef?
Do you want? Yes, exactly. Thank you. How can we ensure that Cambridge's status as a life sciences superpower benefits everyone in Cambridge?
That sounds like a fantastic question. Yes.
Right. Well, I'm going to put that question to Nick first.
You may have temporarily slipped your mind, but when I saw this on the thing, I thought, well, for the Cambridge MP to actually ask a very important question. But it's for me, as the Mayor of Cambridgeshire and Peterborough, to actually say that when I answer this, I'm talking about the context of the whole combined authority area. I've heard a phrase a lot today, and for me, in terms of how we take this forward and answer the question about the superpower status, we mustn't forget the inequality that exists in this city and exists across this region. So for me, the answer is about a question of fairness. We have a problem, and I speak as somebody who's actually an example who moved to the area because my wife initially started working on the health campus here. I followed as well. It's a great place to come, but if you sort of have a huge influx of, particularly in the life sciences, growth and investment, you're going to have a lot of people also very worried about how that's going to affect and overheat house prices. So that's really already been identified in what's called the SPEAR report, the Cambridge and Peterborough Independent Economic Review. And we are an unequal city. So for me, and how we deal with this kind of going forward, we've also got a moral question. So we've got to bring the prosperity in. Why wouldn't we? We want that growth. We want good growth. We want to see access to that kind of opportunity has to come. And that comes in particularly skills opportunities, but also kind of also how we connect ourselves. We know there's pressures on housing, and I would acknowledge, obviously, the City Council around here made a pretty good job of building some council houses. But what I really would like to see, as the Mayor for Cambridgeshire and Peterborough, is to kind of see how the life sciences can benefit not just Cambridge or Greater Cambridge, it's also reaching up to the further reaches of the area. I'm talking about Peterborough, and I'm talking also about Fenland. You know, we talked about a silicon fen, but we've got to kind of really think about, we look at the whole picture. Now, how do you do it? It's called levelling up. It's about sharing prosperity, but it does start about those better skills. And once we can kind of connect things with the benefit of the combined authority, with the investment in an adult education budget, I believe that with better skills, better education, better jobs, you know, we can then start having an improvement in the health and well-being. And that's, for me, is the fairer growth. I've started doing that in terms of changing the way that the combined authority works with a new sustainable growth ambition statement. And that's very much about kind of having a thread through it all, which talks about the improvement of public health, kind of how we get better skills coming in and how that can spread across the whole area. We cannot ignore the fact that we are a superpower, but we cannot ignore the fact that as we get investment, it will change our area. It will change it for the better, but as we change and we have to build more houses and we have to improve the connectivity, I'll willingly tell you about my absolute desire to improve the buses fleet, how we can try and get more cars off the roads here in Cambridge and across the area, reduce the amount of car use to 15%, and that we can get people from the north into the jobs coming here to support the industry. So that's my role. I've got to work with central government. I've got to work with the health campus. And all I'm saying is that if we, again, focus on the inequality, and what we all want to do is reduce inequality. When we create these wonderful drugs, when we create the opportunity, let's try and do that from a compassionate point of view. I'll do that as a politician with my mind still working in the NHS. And I think there's something that we can do which is really special here.
Thanks for that, Nick. Before I go to George for the second answer on that question, Gary, that was in our meeting, the GP from Peterborough and on the CCG. Gary, do you want to make any comment on what Nick's just said? Because you're from Peterborough, you're a practicing GP in Peterborough as well as being on the CCG and part of the RCGP.
So I think what Nick said is absolutely critical. I think we have to improve the life chances, the aspirations, the expectations of good health of everybody across Cambridgeshire and Peterborough. We need to identify what the barriers are. We need to use this asset in Cambridge. So the ripple effect is all the way up to the Fens, it's up into Wisbech, so that the patients up there, the population up there get equal benefit as those living within 2 miles of the biomedical campus. But I think the most important thing is recognising the wider determinants of health and where we're investing. And Tom said it earlier on, we've got all the money going into elective recovery funds, which is the problem of the acute sector. We know that we need to get recovery of long-term condition management in general practice and primary care more broadly. And if you look at where the investment goes in the health sector, it's less than 10% goes into primary care. And we really need to fuel investment into that part of the health sector. We've got to improve social care, and we've got to get Cambridge to be a Marmot city, because that's where the differences lies, and that's where Nick's job lies.
So Gary, can I put you on the spot? You've been in CCGs for a while. Now we have another incarnation, another health system reform. We have the integrated care systems. Your point about primary care links into Tom's point about, addressing the upstream and prevention. How confident are you that ICS is going to make a difference and sort of get rid of some of those perverse behaviours?
I mean, we've tried very hard with the way we've commissioned services across Cambridge and Peterborough with the acute sector over the last couple of years. We've had guaranteed income contracts so that we're not focusing on activity. We're focusing on doing the right thing for the population in the right place. And 9 times out of 10, that's going to be in their own home. That's going to be in their own communities. It's about empowering communities. It's about using community assets. And we should see expansion of our hospitals as a failure of our preventative strategies to keep people out of them. So I'm confident that there's a renewed ambition for integration, but we need to think outside the traditional boundaries of where care is delivered and who's best placed to deliver that care. And the resource has got to follow.
Thank you, Gary.
Thank you.
Sorry to have put you on the spot like that. I hope you don't mind. Michelle, you want to come in there?
Yeah, look, we are one of the country's leading charities, and we invest hugely here in Cambridge. So I just want to add a few points. This is an incredible institute and centre with some of the world's best scientists doing the most brilliant work, and so proud of it. But when we look at where we fund, all of our science is peer reviewed. We fund on the basis of excellence. So when we want to compete globally, we have to focus first and foremost on what are we brilliant as a country, and where does excellence lie? And that's here in Cambridge. This is why the Institute and the Centre is here, providing value for people around the world, developing new tests, treatments, and running incredible clinical trials. We also have to step back and say a theme this evening has been, how do we ensure what we know is adopted and that innovation is applied to local populations? And when you look at cancer survival rates here in Cambridge, there's a lot to be improved. So that interconnection between research, innovation, adoption, implementation and improvement for local populations has to be a focus. And that's why we would be arguing very strongly in a more narrow sense when you look at cancer, but early detection, early diagnosis, working within communities, including the most deprived communities in the area, is absolutely critical to saving lives. So I'd say it's a combination of invest in excellence, bring in partnership with industry, with academia, with citizens locally, and work incredibly hard from the bench to the bedside to ensure that local populations, including those where the disadvantage is greatest, inequalities are greatest, benefit from the investments that we all make. And so it has to be a partnership.
Okay, Michelle, thank you for that. I'm going to leave that question there, if I may, for the moment, but bring in 3 questions in a one almost. Ooh. And this was a question that was prompted by Councillor Corinne Garvey, who's from the Girton Ward in South Cambridge District Council. So Corinne was asking how we encourage life science companies to move into the area. Amy Mason, who's from Bidwells, marketing manager for Bidwells, which is, I believe, a local estate agent in Cambridge.
Others are available.
Yeah.
Others are available, of course. What support is the government committing to for the growth of life sciences across the Oxford-Cambridge Oxcam arc? And then how should central government, and this is from Julia Heckenhast, who's the investment lead at the Office for Life Sciences, how should central government support life science clusters? Now, this is going to have to be pithy because we're on our last 7 minutes. So I think a really good person to ask about how we encourage life sciences companies to move into the area. Michelle, you've already touched on it. Yeah. Tom, you are a life science company, but I'd also like to bring Nick in on that one and what his plans are for that.
Okay. So yeah, there is a challenge. London, Oxford, internationally, Boston, San Francisco, Beijing, and yes, I want people to come here. That's not any doubt. And actually, even before I arrived, there was a life sciences strategy in 2020, which was already commissioned from within the Combined Authority, working with the Cambridge University Health Partners to get a set of shared ambitions. And with the vision for life sciences, I think we're beginning to show some real alignment. So I need to do more work. I need to make sure that I'm aligning, and I have done my visits to the centre here. And we need to kind of talk about how those approaches can complement each other, and maybe, referring to something that George is saying, pick up on this idea of place, and where we know we've got talent here. We know we've hopefully got good investment in terms of finance, but with the name that comes with the Cambridge University, and hopefully with the Combined Authority, hopefully showing leadership from myself, has talked about the improvement. I have talked about the idea of a Marmot City, Gary. We've got work within our organisation. We use the services of GrowthWorks, who have an inward investment team, Locate Cambridge, trying again, showing leadership. I actually sat with the team, the business board, and actually when there was a market access programme, I almost was part of the interview process with people looking to come in. So it is a part of myself and the Combined Authority working with Cambridge University Health Partners. But I want to give one other side to this, maybe away from the science. I want to say, I came here, I'm an example. My wife moved here when she was offered the job at Addenbrooke's. I was lucky enough to then get a job at Hinchinbrook. I've never doubted, although I'm originally from the northeast and I miss it daily sometimes.
You can't tell.
I think I've softened a wee bit. But I'm happy to be here. And my children, born at the Rosie, I look at the opportunities that they get here. So we've got a lot to celebrate. But what scientists like culture as well. We've got to make this a great place to live and work. So as well as absolutely working with everybody in the partners and to improve the connectivity, improving the opportunity for skills and development of the local population, and also improving housing stock, I want to say it's also inherent on me to work with other organisations to work on the idea of developing a sense of identity, which, when you live and work in Cambridge, you're proud about it. So that talks about a county of culture where we celebrate the good things. And that means, when you've had a hard day's work at the lab, you can also go out and enjoy some classical music or a damn good concert down the junction. So that's a little bit pithy at the end. I absolutely give my word that the Combined Authority is dedicated to working with all opportunities in terms of the life sciences. It is something that is in my DNA, no pun intended, from starting as a doctor in 1993. I will continue with that medical love. I will continue working with the life sciences, but will also bring in everything else, because Cambridge is a place I am really proud to be a mayor, and I'm very proud to bring my family up here, and we can celebrate that.
You must have been 15 when you started being a doctor. Tom.
I want to go back actually in answering your question to Gary and Nick's comments on the last one, because being a science-led superpower is about science-led innovation. Cambridge is a brilliant place to do science, but it's also about innovation in data, in technology, and in healthcare delivery. And actually, if I look at where my collaborations on that second agenda are, they're not in Cambridgeshire and Peterborough today. I'm partnered in Wales, in Dorset, in all over the place, but not here. So actually, I think we need to, through the AHSN, through the new ICS organisation,
absolutely,
really open up those kinds of collaborations to benefit patients and address healthcare inequality here. That's going to make this an even more attractive place for life sciences companies to come. And beyond that, we need better connectivity and we need more lab space.
Great, lovely and pithy. Julia, did you want to add something there?
I did want to add something there. I'll come on to the ARC in a moment, but I just want
Don't have too many moments.
Yeah, I haven't had many moments.
Sorry, I was conscious of that. Yes, forgive me.
Thank you. So I would say what we have in this region is a shared ambition, but in the UK, to be a life sciences superpower, we shouldn't be competing for funding between the regions or between institutions. We need to work together. If we're looking for inward investment from Asia or the US, they don't look at, they see the UK as a life sciences cluster in itself. And we've got to present that globally to be a success. So what we need that government commitment to 2.4% to R&D, take R&D spending to 2.4% of GDP by 2027. That would be fantastic.
You got it.
What we need, as Nick said, we need investment in the talent pipeline. We need high quality science education. It's not just high flying scientists that are sort of flown into the Cambridge ecosystem. It's the technicians, the ancillary staff, the support staff, and we need to train those that they're aging, and we need to invest in that talent pipeline. T-levels and degree level apprentices are a great way to do this. And Nick's mentioned all the things we need from ARC, but what we do need, you can't even get from one side of the ARC to the other. I could be in Europe or halfway to Boston in the time it would take me to get across ARC. So we need investment in effective and sustainable transport. And there's a huge affordability gap for scientists in this region as well. So I've had
Julia, you have very pithily. In fact, you've won the Pithy Award of the night. So thank you for that.
Thank you.
Got a huge amount of points across there. I want to finish, if I may now, because we are coming to the end of our time. 10 minutes is telling me now. Oh, that's great. Thanks, Ben.
You missed my train.
Could have waved at it a little bit earlier. Then in that case, let me go. Is Professor Nick Gay in the audience tonight? No? Well, look, he had, I think, a really good question. Professor Nick Gay is Professor of Molecular and Cellular Biochemistry here at the University of Cambridge. And he was asking, what are the scientific priorities for the post-pandemic period, and how will government deliver them? And I'm putting that to you, George.
Okay, great. I'm going to be really pithy because there's a bunch of questions floating around. It takes us back to the missions, actually, the 7 missions. And I think some of the ambivalence on that vote was because people don't know if there's any money allocated to them. Let me just be clear. We're in the process of giving 30 billion to UKRI and Innovate for the next 3 years. And I'm going to be, BASE doesn't really have very much money at its disposal, but I do have the chance to make sure those missions are fundamental, which I'm doing. And DH has just been given about 5 billion for the next 3 years for the NIHR and research. So there is plenty of money in the system. I think the answer to the question is we need to be very focused on what the actionable 1, 2, 3s are. And I was delighted to co-chair the respiratory mission workforce with Jonathan Van Tam and John Bell this week, 400 people on the line, people who are interested in this stuff. And my focus was let's pick 3 things we can do in the next 2 years that will drive the respiratory process. So we go from talk to action. On the city point, I said this to someone who grew up in the county and lived in Arbury for a bit in my Withnail days. I think there's 3 things we should do. One, there are a lot of people in this city and county who don't benefit, to the point the GP made earlier, from this amazing science. We've got to get them involved, get them into trials, get them so that they're benefiting from the actual health. Secondly, schools and skills. Not everyone is going to be a Nobel Prize winning geneticist, but we could be getting more people from the Arbury estate into working in warehousing, working in the sector, working in well-paid jobs in this industry. And I think that's about going into D as well as R. As we go upstream and do more manufacturing, you widen the pool. And thirdly, if we got world-class transport infrastructure, then I think they'd benefit. They'd say, well, I'm not involved in the life science sector, but I live in the most amazingly connected city. On the ARC, to that point, I was very proud when I was at DFT to get the East-West Rail project landed and to get the agreement to bring finally that link through to Cambridge and to kill the idea of a motorway across Oxfordshire. To me, it's about fast rail links, stations as little incubators and 5G business hubs. I remember with Andy years ago driving to Oxford and saying, you must do this every week or two. He said, no, I hate driving. It takes me 3.5 hours, it's terrible. Same with Norwich. If we get Norwich, Cambridge, Oxford, Reading, you're then linking Harwell, you're linking huge technology clusters, and that's really key. On the clusters point, I'm focusing UKRI and Innovate. Clusters, clusters, clusters. Stop giving me, or feeling you have to give me as Minister, 650 announcements in Wales. Let's map the clusters. By the way, there are about 30 in the UK. And then I want to just measure how much they're growing and go to each for a whole day regularly and find out what the thing that's holding it back is. And I think if we do that to the councillor's question, I don't think we're struggling to get life science companies coming into South Cambs. The challenge is to get them going into Peterborough, into Wisbech, into Cromer, into Yarmouth, into Thetford, into the places where we've got deprivation, drugs, human trafficking and crime. That's connectivity. And with fast rail and good digital, we can do it.
And on that, I'd like to bring in Julia, then Michelle, because you mentioned in there a really important piece on the research, and I think that links into Professor Gay's question. the business about getting research at the bedside, clinical research at the bedside, clinical research in the primary care practice, not as it is at the moment disproportionately skewed to hospitals. What's your thinking about getting research embedded in routine care so that when the GP says, you know, well, I'm thinking of giving you this treatment, they're also saying, what trial can I get you into? And how can we make that easy? So Julia first, then Michelle, please.
Well, I think that's, how easy is it to do that? I think it's really important. I think we still need the engine of discovery science before you can even do that piece. And we have to do that piece. And I think we need space where we can bring together co-location of academics. Well, this campus is a great example. Academics, commercial activity, healthcare activity, all working together, but close to the clinic, because that's the only way you're going to do it in an integrated way. I've known research centres and hospitals next door to each other that can't even do that. So there's cultural barriers and there's technological barriers as well. But if we're focused on better patient outcomes, we need to be able to bring these communities together in an open way to deliver that better outcomes for patients.
Thank you, Julia. Michelle.
So continued investment in discovery science is critical. We're talking about innovation, but it is only through science will we discover new ways to prevent, diagnose and treat. That's critical. I think the second thing is that we have a life sciences strategy turned into a plan, turned into implementation. So that broad coalition that's been formed around that strategy, I think it's been great, hasn't it? Needs to continue to focus on delivery. In relation to clinical research, I think what we've seen is not only the decimation of clinical trials during COVID, particularly around cancer, but it is, as you say, a longer term trend. We have to make the UK globally competitive. The NHS is a critical point of differentiation for us. But there is very little time to do research at the moment in the NHS. So that continued focus of time to do research in the NHS, I'd say responsible access to data remains critical. All those issues have been talked about, as well as a fundamental one about trust and patient and public trust in data at the moment. And then we have to, across all parts of the research pipeline, ensure that the UK remains a place where the world, as well as the local communities, best talent wants to be. Because if we're going to compete globally, we have to have the very best talent brought in from our local communities and brought in from the best brains around the world to address some of the big problems we face.
Yeah, thank you. I was just going to say, we can build on some of the activities in COVID, because we talked earlier about the recovery trial, which was set up in 9 days, and it had an innovative trial design, allocating patients into different arms. We need to be able to build on this, and we can do this. And I think because we were able to do that because of continued investment in life sciences and in infrastructure and in discovery science, we were able to apply that in the moment very rapidly and just demonstrate to the world what could actually be done.
And if I may say, I'm going to have to cut it.
Yeah.
If you may.
If I may, the recovery trial, we did a brilliant job. The problem is that everything else stopped. And I think we have to stop thinking about clinical development and routine care as separate things. The evidence is incredibly compelling.
Yeah.
Where you're doing clinical research, you have great care.
And you have better outcomes.
And you have better outcomes for patients. So they need to be integrated.
Yeah.
I think it's a real challenge from a workforce perspective in the NHS right now to deliver on the clinical research delivery plan. But I do think it's an area we need to form a shared partnership, shared funding, shared skill between my industry and the NHS and your department,
the NIHR,
to solve for this urgently.
But don't forget,
William, I'd love to bring you in. The NIHR is here, so if you can only do it in like a couple of seconds. What's up? We've got somebody distressed here. Is there a problem?
ICS, what does it stand for?
Sorry, forgive me.
Local government has not been mentioned.
Well, we're just about to do a poll on that. So integrated care systems. William, I don't know if I'm going to have time, so it's got to be quick.
The point about research for Thank you. The point about getting research to people, when we talk here about superpower and academic and bioscience, it's great for research. When we need to talk about people and getting in research, we talk about care, research care. So your point is absolutely right, because academic and superpower is difficult in primary care and in the home. So translate, use a new language of research when you want to empower people to get involved, and then they will come to it when they see it as relevant to their direct care.
Yeah, the Pithy Award's on to you now. Thank you very much, William. Really great. I am now going to ask the final, or the penultimate final poll. Sorry, I'm really sorry, Nick, but I'm getting, we'll get cut off. I'm going to ask the final poll question, and this does play to your concern about integrated care systems. So, are you confident that integrated care systems are ready to tackle the backlog? So you can answer yes now, if you're confident. Well, that was pretty easy then, wasn't it? Okay. I did say at the end that I'd come back to the first poll question. So how confident are you about the future of the UK life sciences sector? So if you're not confident, having heard this, put your hand up. Still not confident, gentleman over there. Somewhere in the middle, somewhat confident. Yeah, it's more somewhat confident than very confident. I'm going to finish on that poll question. You're not allowed to vote. Had your time. I'm going to finish with an observation. I was doing a bit of a word count during the conversation tonight, and the words that came up, not just from the audience, but from the panel, but also from the audience, the two words that had an even score were inequalities and collaboration. So those were I think, some really good common themes coming out of tonight. I'd like to wrap up the session now. I know Minister, I think, has got a car waiting outside for him, but that's not why I was being pushed. So can I thank you all very, very much? Can I ask you to show your appreciation to the panel in the usual way? And thank you all very much for coming as well.